Okay. All right. So good morning to anyone I've not met. My name is Alex Nissen. I'm one of the R4 PGY5 residents. Today we'll talk about really kind of assessment of a patient's volume status and kind of IV fluid choice and kind of simple resuscitation. But it's something that really the reason we're talking about is because, resuscitation obviously in trauma patients has moved to blood preferentially over IV fluids, but really, if you look at it, most trauma patients, they don't need massive resuscitation protocols. Really, almost all ICU patients taken care of in any hospital need some fluid that is not blood, and there is no perfect assessment of volume status. So as much as, balanced resuscitation and those sorts of things is very interesting, I would argue that this is something that really applies very broadly to almost everyone we take care of, especially probably every single patient we take care of in the ICU. Just a brief kind of outline of questions that I plan to address today are kind of first just a review of what the physiologic endpoints of resuscitation are. What do I mean when I say volume responsiveness? What are the measures that are out there, and really kind of hoping to dive into a little bit of what their relative strengths and weaknesses are so that people can have some takeaways. And then if we have time, we'll try to answer some questions about, okay, so I've decided my patient needs volume, what fluid do I choose? So briefly, obviously we are all familiar with these kind of basic, really vital signs as they apply to physiologic endpoints of resuscitation. None of them is inherently perfect. There are lots of confounders that can be involved, whether it's a patient's age, comorbidities, medications, recent surgery, things that we do to them or things that they have done to themselves before they come to the hospital. And none of these is necessarily great as a static measure, but when trended can be more helpful. Another endpoint that you will see more and more in the trauma bay, it's actually a criteria for which it can generate a major trauma, is the shock index. I would encourage people to be familiar with this. It's just your simple heart rate divided by your systolic blood pressure. A normal is in the 0.5 or so range. When your shock index starts to rise, that would indicate higher heart rates, lower blood pressures, and as values get closer to 0.9, that can be associated with need for massive transfusion protocol and arrest on induction of anesthesia. So good things to have in mind. If it's greater than 1, that's obviously highly concerning, but values less than 1 can also be concerning. So if when we talk about shock, kind of any of the interns want to say kind of what the basic definition of shock is. Not a trick question. Something to do with the end organs. Yeah, just inadequate oxygen delivery to the end organs. So when we think about that, it's helpful to break it down. So delivery of oxygen is, in this equation, this is actually something that can come up and that I would encourage people to have in mind and have relatively memorized as we break it down. But the delivery of oxygen, or DO2, is determined by your cardiac output times the content of your arterial oxygen times a factor of 10. Whether or not that you incorporate the 10 doesn't really matter, but you have to then kind of break it down further and think, okay, what are the components that go into the content of arterial oxygen? So your hemoglobin times a factor of 1.34 for the affinity of oxygen to bind to hemoglobin. The saturation of your blood is actually something that's probably undervalued when resuscitating these patients. It's an easy thing that we can crank up a little bit and maybe get a little bit more delivery from 92 to 100%. And then the dissolved partial pressure of oxygen, is obviously only a fraction of what's actually being delivered to tissues. It's not terribly meaningful. But we can also break down cardiac output, right? I mean, that involves heart rate and stroke volume. So we can improve those things. So now we have more and more measures that we can try to improve when we're really trying to give some targeted resuscitation to these patients. And then what's going to affect stroke volume, right? There's more things there too. We can think about their preload, the contractility of their heart, and their afterload. Those things are all very important. Probably not going to give afterload reducing agents when you're trying to resuscitate someone, because that might worsen their acute hypotension. But there are a lot of things that we can do to their preload, and that's really what we're after when we're assessing their volume status, because we're also probably not going to acutely change their contractility unless we're talking about things like treating their sepsis and anything like that. So when we think about these factors and everything that can go into assessing a patient's volume status and everything that we can improve to target their resuscitation, that's great. But then the next question is, okay, so we have all these things to target, but what do we really mean when we say volume responsiveness? It's a vague term. I think it can mean a lot of things. The simplest definition that I've found and that I think makes the most sense is using fluid as an inotrope, right? It's the ability to give someone fluid, and just by giving them fluid, improve their cardiac output. The way that that works is really this Frank Starling curve that we're all familiar with. You want to figure out if your patient is volume responsive, they would be on some part of the curve around here, where you could give them a fluid bolus and see a 10 to 15% increase in their cardiac output purely by giving them that additional preload. Not be out here. And if they're way down here, you're probably a little bit behind, but they're definitely volume responsive. And so the way that that typically kind of manifests in terms of assessing their volume responsiveness at the bedside, it basically means that you have to give some form of a fluid challenge. It can come as crystalloid, colloid, passive leg raise, all those things are fine. And you want to see, in the literature, you'll see time and time again, this is kind of your threshold. You want to see a 10 to 15% increase in either their stroke volume or their cardiac output, whichever you choose to measure. But you really want to have a good cause and effect in terms of what you give and kind of reaping a benefit. Not just, this is not an increase in blood pressure. This is not an increase in heart rate. This is something that generally requires some form of relatively invasive hemodynamic monitoring or specialized monitoring that we can talk about at the end of this. So when we talk about ways to assess volume responsiveness, there are static and dynamic variables. There are really too many to go over in a single talk, but this will be kind of the meat of the talk. We'll go through some static variables, what they mean, are they even useful, frankly, and then some dynamic variables, focusing really on kind of the EV1000 and Vigileo that we use here, the strengths and limitations, and then we'll talk a little bit about echo at the end of the talk. So static variables to address CVP, that comes up a lot. It's a bit old-fashioned, but people still use it. We use lactate a lot. Mixed venous oxygen saturation or central venous oxygen saturation can also be useful, especially when paired with a lactate. That's really probably the best use of that. And then there's tons of others that are essentially the vital signs that I listed in terms of, end points of resuscitation. And then dynamic variables, whether that's pulse pressure or stroke volume variation, various measurements on echo, VTI being looking at someone's left ventricular output, IVC and SVC collapsibility and so forth. And then thermodilution is probably the best validated measure of someone's cardiac output, but it can be a little bit labor intensive and requires some calibration. So we'll just kind of jump right in. So the commonly used static variables are these that we will go through. When we talk about CVP, so conceptually, it sounds great, right? I mean, you can give a volume, you can measure a pressure change in the right atrium and see, are they going to be volume responsive? Do they have a rise in their CVP, suggesting that maybe they would, have a little bit improved preload and thus have a little bit of improved cardiac output. But really, there are lots of studies that show that it is essentially a meaningless value in terms of someone's ability to be volume responsive. This is a study in septic patients, basically showing that these patients all had pulmonary artery catheters to measure their responsiveness based on an actual invasive change in their cardiac output. Not only do these kind of look like random scatter plots, but you can see that there are patients who had CVPs of 16 and were responsive, patients who had CVPs of 0 and were non-responsive. So this is really not a useful marker of resuscitation. And this is also a fairly old study. So I should just kind of, when someone brings someone to the ICU and they want you to trend CVPs as the sole marker of resuscitation, maybe you start digging through the literature and look for more up-to-date stuff. This is a similar study in patients who are healthy volunteers. These patients, probably medical students, had central lines placed and arterial lines for transpulmonary thermodilution to measure their cardiac output. And you can see that, there were some patients who, when given a volume challenge, their reduction in CVP was actually negative. So their CVP went down despite their change in stroke volume index going up. So they were volume responders and had a reduction in their CVP with a fluid bolus. It's effectively kind of a random number generator. It can be useful intraoperatively. It can be useful for other things. It's not terribly useful at the bedside. So the next thing that we might talk about is their mixed or central venous oxygen saturation. This is essentially a marker of oxygen extraction from the tissues. It ties very nicely to the definition we used earlier for shock in terms of end organ oxygen delivery. That should be linearly related to end organ oxygen extraction. And so mixed venous O2 saturation is truly taken from kind of the right ventricle or the pulmonary artery. That value is a little bit lower because you get coronary sinus blood and things like that. Otherwise, you can take just a central venous oxygen saturation. Sorry, I'm looking for my cursor. And that'll be a little bit higher to be in the normal range. If it's low, that's when you start to think about causes of hypoperfusion. Patients are having high values of extraction, some form of end organ hypoperfusion, causing them to extract more oxygen than the normal individual. So if that is paired with the lactate, this table can be very useful. But really, if the SCVO2 is low and the lactate is elevated, that is really kind of the setting in which the picture fits best for under resuscitation or hypoperfusion. Those are the patients that are probably most clearly going to be your volume responders. But this is, again, kind of a static value, probably best trended. And then there are some unique situations where patients can actually have elevated CVP or elevated SCVO2. And it's actually just because the microvasculature is deranged and they're actually having poor oxygen extraction at the end organ, whether or not they're hypoperfused, namely severe sepsis. So just because a patient has maybe an elevated SCVO2 doesn't mean that they are over resuscitated or not under resuscitated. You kind of have to use it in the full context of the patient. Other things listed there are less common. We don't really treat a whole lot of hypothermia and cyanide poisoning, but we may see patients in fulminant hepatic failure. And then especially in the trauma population, we may see people who are acutely paralyzed and may have elevations in their SCVO2 despite being relatively under resuscitated. And so that's my last point, is really that when coupled with lactate, it becomes a more useful static marker, but still not perfect.
Because I've always used that as really when you're trying to, if the differential is severe sepsis, it helps to, as a static marker, helps differentiate if this patient's septic shock or cardiac venous shock.
I think that can be helpful to differentiate. Are they having hypoperfusion for this reason versus that? But if someone is, marginally hypotensive and you're trying to run a little hypotensive resuscitation, I think you could trend this, and once their SCVO2 normalizes and they're hanging out right at a map of 60, but they're mentating, you could say, hey, let's stop. Maybe they don't need more fluids. That's, I guess, the situation I'm getting at. But if you wanted to use it statically to say, do we think this patient is septic? I suppose you could. I didn't really look at it from the perspective of differentiating types of shock, more so determining when your resuscitation can kind of slow down.
Okay. I think it's tricky, but just because a lot of patients we have that we treat that have shock, that is not hemorrhagic shock,
yeah,
more often than not septic shock.
Yes. Yeah.
But I mean, it's good point.
Yeah. And then, so really, I only wanted to touch on those few static variables and spend a fair bit of time talking about dynamic variables. So again, this gets back to the concept of you deliver a change in preload and you look for a cause and effect, and you look for a change in either cardiac output or stroke volume. You really want to see that cause and effect. So the examples that we'll go through, primarily pulse pressure variation, stroke volume variation. We'll talk a little bit about IVC collapsibility on echo, and then we'll maybe breeze through thermodilution, but that can be a nice measure of a patient's true cardiac output, but it can be prone to errors in calibration. So IVC collapsibility, it's important to really know for all of these measures in what setting are they validated. So first, IVC collapsibility was really validated in patients that were mechanically ventilated, not spontaneously breathing, so not able to generate a negative pressure breath against the vent, receiving relatively high tidal volumes. And if those criteria were met, which is seen in a fraction of ICU patients that we take care of, and the collapsibility was greater than 15%, it can be suggestive of volume responsiveness. Now, if you recognize the limitations of any of these measures that I'm going to talk about, and you're willing to kind of apply them and have a knowledge of those limitations, you can still use them. But in spontaneously breathing patients where instead of a positive pressure breath, a negative pressure breath is what's generated, obviously your IVC collapsibility is going to be much greater. So the threshold for volume responsiveness is closer to about 40%. Alone, it is not perfect, but as part of a broader echo assessment, it is probably a very nice adjunct, a kind of another data point, certainly something that you could trend, but as a single shot in time, maybe less useful. So what about pulse pressure or stroke volume variation? So in a normal individual who is breathing spontaneously, there will be changes in the amount of blood that is either staying in the lungs or being essentially delivered to the heart as preload based on the respiratory cycle. This really is not actually flipped on its head. It's just more so exaggerated when patients are on positive pressure ventilation. And so even in someone who is normally respiring, you should see kind of some of these changes in terms of the pulse pressure, which would just be the peak of this to the base, the peak to the base. And you'll see that it would narrow during periods of inspiration and it would widen during periods of expiration. So whether you use the pulse pressure, which is just these numbers, or the stroke volume, which is going to be the area under the curve to measure cardiac output, that can give you a real beat to beat measure of someone's cardiac output. And it can, by virtue of, collating every single beat, it's never a static endpoint. It's something that's always changing. It's something that's always being measured. That's what makes it particularly attractive. So this is just the equation for it for those interested. Stroke volume variation is calculated as a percent without really a unit. And then the way this is done, we use it has undergone many name changes, but whether you call it the Vigileo, the flow track, or the EV1000, I think everyone will know what you're talking about. It can measure a number of things. This is generally what one of the screens would look like, and it will display for you, for instance, the stroke volume variation. The absolute numbers are probably less helpful, but the stroke volume variation is probably what can be most helpful. In patients you actually don't want to, put in an invasive line, there is also this ClearSight cuff. It's actually kind of a blood pressure and plethysmography cuff that goes on the finger and can measure the same beat to beat variation. So it is something that can be done non-invasively. So the flow track can measure all kinds of things. The one that we'll kind of focus on is the stroke volume variation. So how well does it predict fluid responsiveness? Generally, for a pulse pressure variation greater than about 12 to 13, or same for the stroke volume variation, that's used as kind of a threshold based on meta-analyses of these patients as kind of, are they fluid responsive, are they not? How do you deliver that fluid bolus is really up to you. You can do a passive leg raise that will deliver generally what's recognized as about a 300 cc auto transfusion within about a minute. So you need to have this stuff already set up, already calibrated, ready to go. I would not do this in patients you're concerned about a neurologic injury, obviously, because you have to put them head down and raise their legs. And then it's not validated in patients who have intra-abdominal hypertension. And then varying papers will use either a 500 cc crystalloid or 250 cc colloid bolus. And like I said, you should see that change in cardiac output really promptly. It's not you do this and an hour later their CO goes up and you say, oh, they're volume responsive. It really is something that should be fairly immediate, because you should be changing their preload fairly immediately. Again, really only validated in patients who are on non-spontaneous continuous mandatory ventilation with relatively large tidal volumes in sinus rhythm. That's actually very important, and actually not on vasopressors. So it's really more so validated in probably the patients that we're operating on while anesthesia is managing them on the other side of the drape. These are kind of settings on which someone might be when they're paralyzed in the operating room and are using higher tidal volumes. But again, if one recognizes kind of the limitations of these measures, you can apply them kind of in good context. But in that specific population, it's both sensitive and specific kind of to values above 80 to 90%. It can also be useful if you're concerned about titrating PEEP and issues with RV preload. But that is kind of a separate topic for anyone interested. And then another way to measure a dynamic measure of resuscitation would be measurement of cardiac output. It's generally going to be done with a Swan-Ganz or a pulmonary artery catheter. These are normal values for anyone interested. Much used to be made, like CVP, about pulmonary capillary wedge pressure. We'll talk a little bit about that in a second, but probably also more of a static variable than a dynamic variable. So when considering pulmonary capillary wedge pressure, this is why it's really not a great variable unless it's in the OR, probably for a cardiac surgery or a liver patient. But so pulmonary capillary wedge pressure, that is a surrogate for left atrial pressure, right? Which is also a surrogate for left ventricular diastolic pressure, which is a surrogate for left ventricular end diastolic volume, also known as preload. So you're about 4 or 5 degrees of separation away from what you're actually trying to assess. That's why this is not such a great value to use as a static endpoint. There are studies very similar to those CVP studies I showed that essentially show that if you're using pulmonary capillary wedge pressure or pulmonary artery occlusive pressure as a endpoint of resuscitation alone, it can effectively be a random number generator. It's not something that should really be the sole driver in your management. Same study, normal healthy volunteers, just like the Delta CVP figures I was showing earlier, there were patients who had no change in their pulmonary artery occlusive pressure and a 20% increase in their stroke volume index. So it's not necessarily the best value, but Swan-Ganz catheters can still be useful for measuring cardiac output through thermodilution, whether it's done transpulmonary or through kind of the conventional method where a known volume and temperature of cold saline is injected directly into the right atrium. There's a thermistor at the distal tip of your pulmonary artery catheter, and there's an algorithm that measures the change in temperature over time and then calculates the area under the curve and gives you actually a very accurate cardiac output. Like the Vigileo, it has significant limitations based on whether or not a patient has significant tricuspid regurgitation, intracardiac shunts. Low cardiac output can falsely elevate these values, and then catheter malposition is obviously an important consideration. So, but collectively, when using one of these dynamic variables, they are almost universally regarded as more sensitive and specific than static variables, to the point that in the most recent Surviving Sepsis campaign guidelines, they've actually made it into guidelines. We should probably be using dynamic over static variables to predict volume responsiveness. It's more so recognizing the limitations, choosing one that works well with your patient, and kind of using it effectively and kind of knowing how the systems work if you're going to apply it accurately. This is just a receiver operator curve. I'm sorry that got a little cut off on the screen. It should say changing paradigms, but these are, sensitivity and specificity, pulse pressure and stroke volume variation are here. And these are kind of a collection of other static variables that clearly are more or less 50-50 in terms of their predictive value. What is ultimately the best assessment of volume status? It really probably depends on which patient you're talking about. Some would argue that it's echo. These are teachable and learnable skills. This is a very nice publication actually in military medicine from a collection of military surgeons and folks at shock trauma that show just 4 conventional echocardiography views that can be used to, as they call it, do kind of instead of a fast, it's called a free, but is a quick bedside assessment of a patient's volume status, contractility, and likelihood of responding to a fluid bolus. And here are just some of their outcomes from that same study, if anyone is interested, in terms of the predictive value of change in cardiac function, their afterload status, volume status, and so forth. So I know that I kind of blew through that pretty quickly, but if you arrive to a conclusion that you think your patient might be volume responsive, kind of the next question is, okay, which fluid is best? And is any fluid particularly better than another? We'll talk a little bit about some studies just in ICU patients, and then briefly about TBI patients. So this is a study from JAMA in 2015. Sorry, I'm not sure why things are getting a little cut off on the monitor, but basically they looked at a relatively smaller cohort of ICU patients receiving either saline or some sort of balanced crystalloid resuscitation, whether it was Pedialyte or LR, and basically saw really no differences in risk of AKI or risk of death. So not necessarily a nail in the coffin for either. These studies were basically repeated on larger scales in the New England Journal of Medicine. Among patients who were critically ill, there appeared to be some benefit of using balanced solutions as opposed to saline, namely with regard to the need for new renal replacement therapy. It was a composite endpoint, so that also included death, but really it was driven by a need for new renal replacement therapy. But then in non-critically ill patients, again, kind of no difference whether you use LR, Plasmolite, or saline. So what about saline versus albumin? This is a little bit of an older study looking at differences in patients with severe sepsis or septic shock. Whether or not you use albumin or not, it did not necessarily change your probability of survival. It did not have a gross volume sparing effect. I know that's frequently why we use it, but really kind of no difference in meaningful outcomes at 28 and 90 days. And then a subgroup analysis, or sorry, this is a similar study showing so this was their follow-on study, the SAFE investigators. This is the older study that really was kind of the genesis of all this. Also, again, no difference between saline and albumin, and no real major differences in important subgroup analyses. The follow-on study using a post-hoc analysis of the TBI subgroup in the SAFE trial showed that albumin may be harmful in the setting of TBI. So that's one setting in which you could be interested in not giving a patient albumin as opposed to a simple crystalloid bolus. And then really these have fallen out of favor at this point, but we can talk about saline versus hypertonic solutions. This was an early randomized controlled trial in patients with traumatic shock. There was no difference in the early results in terms of patients who received basically head of starch versus normal saline. But follow on larger studies, again, in the New England Journal of Medicine, demonstrated in patients who had sepsis as opposed to traumatic shock, an increased risk of either death or eventually the need for, this is a similar but different study, or a need for renal replacement therapy and increased serum creatinine despite no changes in urine output. So these patients can have non-oliguric renal failure if you're going to give them a head of starch compound, which is really why this has all fallen out of favor. So I know there's a bit of a whirlwind. That is my last slide, and we can open it up for questions or comments from anyone. Yes, sir.
So, and I'm sorry, I was just correcting myself. Did you mention the SALT PD trials out of Vandy?
I did.
We changed our processes completely there to use plasma-like. Even everything that we could hang with an antibiotic that was compatible with plasma-like, we got rid of saline across the board, across all the ICUs.
Okay, I did not. These are mostly in septic patients, like the New England Journal studies, and then the SAFE trial.
But the SALT ED looked at both critically and non-critically ill. There was a benefit enough for us to make changes in regards to using plasma. Plasma became the go-to solution when you're going to need to hang a fluid. Plasma was the solution we went to. Almost uniformly, except for probably not the neuro ICU. They love salt.
Yes, sir.
So for the endpoints of cessation, the dynamic variables, stuff like that. I've been a doctor for like 16 years, and I feel like it's a rotation of this is in vogue, and then a bunch of studies come out showing that it's random numbers, no better.
Yeah.
I mean, the normal clinical endpoints we use, like burn output, hemodynamic status, always seem to be what we kind of fall back on. I'm curious about, some of the really old people in the room probably going to see more stuff.
Yeah.
What do you think I really?
Yeah. Why are you pointing in John Fletcher's direction when you say that?
Anyway, I guess I'm a little skeptical. Like, even like the Vigileo, that one's sort of stuck around for a little while. But
yeah, no, I think it's very hard. Yeah, I mean, I think you really have to recognize those limitations and.
It's like we use it when it's good, and then when it's not good, we say, "Oh, well, they're paralyzed."
Yeah, well, and I think the other thing. Sorry, go ahead.
I was going to say too, like how many of the patients in our STICU meet the criteria on which it's been validated? Because
very few. In other studies that mention a number, it's in the 10% range. It's low. But
so my question is, the TTE.
Yes.
Or you think it's the best?
Yes,
the
I do.
one, right?
Yes, 100%. It is absolutely the best. It's a teachable skill. It's the best part about it.
So if that's the case, how do we teach ourselves that? Because I mean, like in the last few years, when I've had patients who were ill, and seems like the critical care fellow will come in, not Fletcher, but everybody else comes in and they say, well, like, I can't really get good views, and that's always sort of the answer. Like,
so I think that's the problem is when we are asking for a TTE from cardiology, it's different than what I'm describing. I
guess.
But even with poor reviews, you can get enough info to assess volume responsiveness. It's not, you really need very few endpoints, I would argue. I mean, John and anyone else can correct me, but for a right-sided assessment, I think you need a global assessment and then plus minus one hard marker like TAPSE. And then for a left-sided assessment, again, your global assessment plus minus one marker like EPSS is probably all you need for a gross assessment of their volume status. And those things can be learned. There are great resources online for those interested at the Maryland Critical Care Project, a full ultrasound series